Hi everybody. So gonna get started with chapter 21, respiratory dysfunction. I do want to let you know this is very long. There's about 70 or 80 slides. There's a lot of content with respiratory. Most of it should be a review and just with an emphasis on how it applies to pediatrics. So we'll be talking about patho, we'll be talking about anatomy, but as far as the respiratory system, hopefully that's not something that's so very new that you're feeling lost and confused. So I do want to recommend that you take some breaks throughout this. I will be needing breaks as I record it, and take some good notes, and then we'll go ahead and get started. So, quick review when we're talking about, respiratory system, respiratory infections. We're looking at upper respiratory tract, including your nose, your pharynx, your larynx, and your upper trachea. Lower respiratory is going to be that lower trachea, your bronchi and your bronchioles, and the alveoli. And then for croup syndromes, which we're going to talk about specifically in a little bit, we're talking about infections of the epiglottis or the larynx. Now, it's important to remember these pieces because when you're assessing a child and you're listening to lung sounds and their audible respiratory noises, as the registered nurse, you should be thinking, oh, I hear this noise. That correlates with this piece of the anatomy. It could be X, Y, or Z issues. And so we're going to be talking about how that's going to inform your assessment, okay? So these next couple slides are some basic overview uh, of respiratory issues in kiddos, and these are important because when I, even as a nurse, before I was a nurse practitioner, worked in peds, 90% of what I saw was respiratory related. And so these next few slides hold all of that general information that help inform your critical thinking. And remember, when we say that, that means that if you know generally what viral infections are common in kids, if you know what pathogens are common in kids, then when you're hearing these noises and doing your assessments, you can already begin to formulate in your mind potentially what's going on, which will then inform your decision making. So, RSV, that's a big one, especially in our younger age groups. Group A, beta hemolytic strep, also known as strep throat, is the most common one. Then we have staph, we've got some mycoplasmas, the pneumococci, the chlamydia trichomatices, and then the H. influenza. So keep those guys in mind. Age, this is a big factor in how you as a nurse are going to respond. Also, how the child themselves and their body will respond to the respiratory infections. So obviously our younger kiddos, anyone younger than 3 months, are going to be at a more significant disadvantage. Oops, sorry, no. From over 3 months, anyone younger than 3 months still has those maternal antibodies, which are offering extra protection, okay? After that, when the maternal antibodies essentially go away and now the infant is relying on its own immune system, we're going to see that infection rate increase, particularly from that 3 to 6 month range when their system is essentially starting over. In our toddlers and preschoolers, we see a high rate of viral infections. Think about that. Toddlers and preschoolers, if they're going to daycare for the first time, if they're going to preschool for the first time, again, that's a new shock to their system. They're being introduced to significantly more pathogens more often. I will leave it at that for now. And our kiddos older than 5, we're going to see a big jump in our strep throat infections and in your M. pneumoniae infections. And obviously then, if immunity is rough after 3 to 6 months, when they're developing it, we're going to see that increase with age. Now, middle childhood is a time when there's decreased infection rates and that increased immunity is being built. And part of this is because the lymphoid tissue increases within the body. So they've had exposure to new pathogens. Their body's like, oh, hey, we can do something about this. And beginning to really build that up for the kiddo. So the first time, if they get an RSV infection, it's going to look really bad. But if they get RSV then again later, their body has built some immunity to it. Their age is probably greater. Therefore, and we're going to get to this in just a second, the size of the respiratory system increases. Therefore, the infection and its manifestations are not as severe. So remember, kiddos from 6 months roughly to 3 years old are going to react more severely to a respiratory infection than a kiddo on either side of that age range, as a general rule of thumb. That's not always true, but it's general. Okay. So like I said, the size, the anatomy, this really plays a factor into how severe respiratory infection is, how their manifestations come to be, how their bodies handle the symptoms that develop. Because one main reason in our younger kiddos, the diameter of their airways is smaller. The distance between these structures is shorter, which allows organisms to move more quickly. So in these first two pieces, what we're really thinking about here, so if the diameter of the airway is smaller, that means that when the mucous membranes become swollen and inflamed, and when there are increased secretions, if you already have a smaller airway, and now we're filling that small space with this other goopy, yucky stuff, then that leaves less space for air to get through, for air exchange to happen, etc., etc. When we're talking about structures being closer together, there's a couple pieces here. Particularly thinking about what we were just talking about with the age. So it's going to happen more quickly for the younger age range to have a lower respiratory involvement then compared to your older kids who just have an upper respiratory infection. They have a cold. And your younger children, with the distance between all of these structures being much smaller, that means that it's easier for those pathogens to get down deep into the lungs more quickly. And then the eustachian tubes, if anyone forgets what those are the little tubes connecting your nasal passages up into your ears. And that's why we're going to be talking about here shortly ear infections and why they're so prevalent in the younger age range, because those tubes are more open, they're shorter, and the angle is much different than as it will become as you age. So here's where I'm talking about, again, the anatomy piece, the age piece. When we talk about growth and development, it also refers to the physicality of the child, not just like the psychosocial and cognitive pieces that we've been talking about, but the actual physicality of the child. What's their age? Okay, if I have a 3-year-old, what can I expect out of their airways? How big are they? How close are they compared to your 9 or 10-year-old? Those are pieces that you have to take into consideration during your assessment with a real patient, and those are things that should be triggering flags in your mind when you're reading exam questions, okay? Now, another factor here when we're talking about respiratory in kiddos is resistance. So, we have immune system deficiencies, and that can range from simple to more complex. So our simple deficiencies, and if we have a deficiency, remember, what does that mean? That means that you're more likely to become ill more quickly compared to somebody who doesn't have that same immunocompromise. So simple here would be asthma, Also allergic rhinitis, a history of a previous RSV infection. We're going to talk about why that's specific to RSV later. Daycare. That is a huge factor when we're thinking about immunocompromise. Why? Well, like I said before, you've got kiddos coming in for the first time, building up their own immunity, and the viral infections are just so there's so many different viral infections being passed around at daycare because we know little kids, they like to put everything in their mouth, they drool all over each other. No matter how hard a daycare center may try to keep everything clean and sanitized, it's still going to happen. And then another one is down here, exposure to secondhand smoke. That's a big piece too, okay? Now when we're talking about the complexities, so we've got your cardiac anomalies, that plays a big factor in it. Particularly cardiac anomalies that cause pulmonary congestion, okay? Because then it's affecting the lungs already. Then we have CF, or cystic fibrosis, and we're going to talk about that specifically later, and you'll get a better idea if you don't quite grasp why that's there now. And another one is bronchopulmonary dysplasia. So big words, big issues, things that we're going to talk about. But keeping in mind, in general here, whether it's something simple or something more complex, it's kind of on that continuum and thinking about how that will affect the ability to, one, fight off pathogens and what manifestations of a respiratory infection are going to look like. So seasonal variations. I know everybody has heard, at least I think I've said it a few times already, it's respiratory season. So what does that mean? We see an increase in respiratory infections, both upper and lower, during the winter and spring times. We're going to see the most common pathogens that create kind of that epidemic type illness in the winter and spring. Your mycoplasmal infections are definitely more common in fall and early winter. Infections related to asthma, we're going to see related to that cold weather, so winter, and even early spring, especially here in Alaska with the way that our seasons roll. And then RSV itself is typically winter and early spring as well. So as you can see, most of these are going to be in your winter and early spring, and that may vary based upon demographics, but definitely thinking about here in Alaska, we're seeing respiratory season sometimes start mid-September and last all the way through end of April, beginning of May, sometimes depending upon what our weather looks like, what the virality of things are that year. It just kind of varies. So in general, still talking generalities here, your manifestations are going to vary with age. Now there is a nice overview box that I like on page 637 in your book. It is 21.1. It gives a nice breakdown of each of these things and really provides some good differentiation. So please, please, please take a look at that box. Because it goes over these generalized signs and symptoms and the local manifestations and how they differ in the kiddos. But in general, you're going to see these generalized signs: fever, lack of appetite, vomiting, diarrhea, abdominal pain. Those are not very specific. Cough, sore throat, nasal blockage or discharge. Okay, a little bit more specific. Now we know for sure we're talking about upper respiratory. Respiratory sounds, obviously, both that you're auscultating within the lungs and those that you can audibly hear. Those are going to differ based upon where the infection lies in the body. You're going to hear a different sound if it's in the epiglottis, larynx area compared to if you've got, some wetness in the lungs. So really understanding that basic piece of your physical assessment. And that's not just on kids, that's in general. If you're feeling like that's a weakness of yours, I highly recommend that you do some study work on that. Google videos, listening to lung sounds, remembering where to put your stethoscope. The audible upper respiratory sounds, stridor, audible wheezing, those are things that you're going to be able to have to differentiate, okay? So remember, box 21-1, page 637 is a great place to review this information specifically. Now, general nursing interventions for respiratory infections. Normally, I don't go over it in such generalities like this, but because it is respiratory, they usually end up being very similar despite whatever pathogen it is or where it's, manifesting in the body. So your number one thing is obviously easing the respiratory effort, and that is a really all-encompassing intervention that includes both your medical emergency side, like a child in respiratory distress, to just repositioning somebody in bed for a reduced breathing effort, okay? Managing fever, promoting rest and comfort. I know that sounds really basic, but if anyone's ever worked or had, a 3-year-old who just does not feel well, making them comfortable, giving them an extra pillow, making sure their temperature is where they, want it to be, makes a huge difference. We also want to control infection and prevent spread, which we're going to talk about more in the communicable diseases piece, but obviously important here. Please promote hydration and nutrition. Kids that don't want to drink or eat, if they don't do that, then we're going to have secondary issues. And providing family support and teaching, because for some families, at some point, their child is going to have their first infection ever. For kiddos who are born, sometime in the summer, early fall, that can look, think 3 months in from, like, say, my due date, October, so November, December, January, right smack dab in the middle of respiratory season. So being patient with families, offering support, helping them cope, going to be very, very important, okay? And the only other thing that's not listed on here, because it's not technically an intervention in the way that we're talking about, but please do get assessments, okay? Head, ears, eyes, nose, throat. When we talk respiratory, it's not just the lungs. It's the whole upper respiratory and lower respiratory system. That's why we had that brief overview on the first slide. We're looking at respiratory rate, but also the depth, the rhythm. What's their oxygenation? Simple intervention, throwing an O2 set on a kid gives you so much information. What's their hydration status? Do they have a temperature? And please, please, please remember that a fever is not a true fever until it's 100.4 degrees. That is the true fever. All daycare centers don't follow that, but that's a true fever, 100.4. Also, when you're assessing a kiddo, and especially when we're talking about respiratory, what's the activity level of the kid? Are they still running around the room, or are they sitting there and looking ill? My philosophy on sick kids, no matter what system disruption we're talking about, when I walk into a room, whether it was as a nurse or a nurse practitioner, and I look at that child, there is sick and there is not sick. And what I mean by that is, could they still have an infection but be plunked into my not sick category? Absolutely. That would look like your kiddo with a cold who just kind of doesn't feel well, might be a little bit extra whiny for the day, but is still playing, interacting, talking, won't necessarily be clinging to mom or primary caregiver. My sick kid who needs intervention right now is the kiddo who, even if they're not having difficulty breathing, doesn't want to let go of mom, doesn't want to interact, not interested in toys, whether it's your toys in the office or toys that they brought from home, doesn't want anything to drink, doesn't want anything to do with popsicles, okay? So kids are sick or not sick. When I see them, I make that assessment decision right away. And from there, then I prioritize what my interventions are going to be. A really good one, too, as far as when we're talking about assessment, can the child talk to you without sounding winded? This will be especially prominent when we're talking about like kiddos with asthma and wheezing. If they can sit and have a conversation with you without being winded, we're not as concerned. If you're trying to talk to a kid and they're going like this every other word, even if they look and are sitting there playing with toys, that should be elevating your concern out of that assessment, okay? All right, so next. One thing I'm going to try to point out as we go along too, because it comes up a lot. I got asked this so many times as a nurse. What about over-the-counter stuff? So when we're talking about some of these interventions that you can do to promote rest and comfort specifically, age plays a large role in what can be given to kids, obviously. We've talked about medication calculations being weight-based, but then there's this age component, which is more for your over-the-counter stuff. So things like a vapor rub, like a Vicks vapor rub, those can be used in kids in 2 and over. And it has to be used in a place that's not directly below the nose. So, not in the upper lip area. Excuse me. Putting it on the chest. I know some parents will put it on the feet. Whatever. As long as the child is over 2 and it's not directly below the nose, whatever works for them. Bulb syringe. Depending on the kiddo's age, I've used a bulb syringe on a kiddo up to 6 or 7, just when the boogers were so packed in there, and they weren't having good luck blowing their nose. That promotes comfort because then they get a moment to breathe through their nose. Okay. Saline drops in the nose. That sounds uncomfortable, but if you use it in conjunction with a bulb syringe, can actually moisten the nose and the mucous membranes in there enough that some of those really, gross, dried up, packed in discharge can actually be moved around and pulled out. And that can provide a big difference between a child being able to fall asleep and not fall asleep. Steam and cool mist, we're going to be talking about how those will be applied to specific disruptions, but as a general rule of thumb, I recommend, especially in respiratory season, especially here in Alaska because it gets so dry, I recommend to most parents to have a humidifier going in the room near where the kiddo is, because that can make a big difference too. So again, thinking pediatrics, basic interventions. It's not always glitz and glamoury, running in there with all sorts of fancy stuff, but these are effective interventions that you can recommend to families. Okay, so now let's start talking about some of that specific stuff. Our upper respiratory tract infection, also known as a URI, also known as acute nasopharyngitis, also known as the common cold. Numerous viruses cause a URI, and that ranges from RSV to rhinovirus to the flu to parainfluenza. Okay. Remember, again, severe symptoms are going to be in your younger kiddos. And when we think about adults, this is going to be in those who are, mostly immunocompromised or have something else going on. Page 641, there's a box 21.3. I think it is very good as well for a study tool. So please take a look at that. Fever and the other symptoms are roughly going to be age dependent when we're talking about a common cold. How often have they had this kind of viral infection before? Is it the first time or is it the 6th time? That's going to make a big impact there. And so for a common cold, as much as parents hate this, there is no specific treatment. We're not doing antibiotics for viral infections, okay? Now, the American Academy of Pediatrics recommends no over-the-counter cold medicine in children under 4 years old. As a provider, I usually still don't recommend over-the-counter medications. If a child is coughing, the body needs to cough, okay? That, from my perspective and my philosophy in care, that changes as kids become teenagers and are closer to that adult range. But for the most part, if a child is coughing, it's for a reason. Either their body is trying to expel something that's there, or they're trying to pop those airways open using that pressure that you get from when you cough. But the overarching recommendation by AAP is no over-the-counter cold meds under 4 years old. Okay. And two, remember, the common cold is probably going to be one of the first times that a family is dealing with this particular child being sick if they have multiple kids, or if it's a first-time parent, the very first time their child is sick if the child's been healthy previously. So there's going to be an elevated level of concern and anxiety coming from the family, and as the nurse, it is part of your role to provide that support. Okay. All right, pharyngitis. So, sore throat. I can't tell you during respiratory season how many acute viral pharyngitis kids I'll see. Now, I said viral, but pharyngitis can also be caused by bacteria. So it's a viral or a bacterial cause. The most common bacterial infection is going to be that group A beta hemolytic strep. So group A strep, also known as strep throat. We worry about strep throat because if they're not treated in a 10-day window, kids with group A strep are at risk for rheumatic fever. And that can lead to a whole slew of issues, inflammation, disease of the heart, issues with the joints, central nervous system issues, acute glomerulonephritis. So it's a very delicate triage and assessment piece that nursing has to do, even in the outpatient setting, which is where most of these kids are seen, in doing a good assessment and figuring out what signs and symptoms are presenting, how long has this been going on, et cetera, et cetera. Okay. Because, and I put the emphasis on that because the signs and symptoms for pharyngitis can range from subclinical, meaning that there are none, to a severe case leading to like toxicity. But when we're thinking the group A strep throat, you're going to have abrupt onset of symptoms, usually sore throat, headache, fever, and abdominal pain. You will find all of those with a group A strep pharyngitis. What you will not typically find is your runny nose or your cough. If you've got a kid that is complaining of a sore throat, a runny nose, and a cough, then it's usually a viral pharyngitis with your common cold, okay? So really important to kind of differentiate for those pieces. Particularly, again, thinking about our strep throat, kids older than 2 is where that's going to be most common. Kids under than 2, group A strep is not as common. Oops, wrong way. There we go. The other piece, which is not as often seen, but I still check every kiddo when I'm doing my assessment, when they have a sore throat, is looking for a fine sandpaper type rash that will be on the trunk, in the armpits, could be on the elbows or in the groin. And this is the same kind of rash that's also seen in scarlet fever. Okay, and that's caused by a very specific strain of the group A strep. So I always look for that in the kids because it's going to be a big giveaway if they've got that. But not everybody with strep throat will have it. Okay. So for treating our bacterial pharyngitis, so your strep throat, it's going to be an oral penicillin or amoxicillin for 10 days. There is an IM version, but it's not the first choice. oh, I skipped diagnostics, sorry. So when we're trying to determine what's going on here, is it bacterial, is it viral? It's a throat swab, right? Most people have had a strep throat swab at some point. There's a rapid, and then there's the send out. What I will tell you, since I've started working as a nurse practitioner, I've seen more negative rapids and then positive send out cultures than I anticipated. Because the rapid really only tests for group A, because that's important to know within that 10-day time frame. But that doesn't mean that it can't be a group B strep. And that comes back, a day or two later, depending on where it gets sent to. And so make sure you're educating families about that. Okay, if you're the office nurse, the rapid strep is negative. We still have the send out swab. We will call you with those results. For your nursing management, therapeutic type management, if you're waiting on that last one, symptomatic supportive treatments. Tylenol or ibuprofen for aches, pains, and fevers. Increased fluids, etc., etc. Other specific nursing considerations here include making sure families are educated that they are infectious from the onset of symptoms for our group B strep, or I'm sorry, our group A strep and our strep throats, infectious from the onset of symptoms to 24 hours after starting an antibiotic. And the child will need a new toothbrush. And I know that sounds silly, but I have seen so many kids come back reinfected after they finish their course of antibiotics from self-inoculation with their toothbrushes. Or children with siblings who swap toothbrushes, same thing. So these pieces in the education there are really important. Okay, taking a look here, you've got a combination of pharyngitis. So you see all this redness up here in the, oh man, keep hitting the wrong button. All this redness in your tonsillar pillars and your soft palate up here. Then we're going to jump into tonsillitis here in a second. And so here you can see this exudate back here on the tonsils. You may find exudate in just plain old pharyngitis. And you may find tonsillitis without exudate. So it just depends. It's not 100% always one or the other. All right, tonsillitis, pretty common. I feel like most people know about it. Your patho here, remember the proximity of the pharyngeal tonsils, or the adenoids, and the palatine tonsils, so the ones that we were just looking at here, these guys that stick out. The proximity of those to the nares and the eustachian tubes is a great example of how that close anatomy leads to higher infection rates in our younger kids especially. The term kissing tonsils is when we have severe swelling and edema, which your tonsils are literally touching. So we're looking at a 3-4 plus as far as the assessment. And this is an issue because it causes what? An obstruction of the air or food. So they have difficulty breathing and swallowing. Additionally, when we have kiddos with tonsillitis, if it's ongoing or severe, if a parent tells you that their child goes from being a quiet nose breather to a very noisy open mouth breather, that should key you into some key anatomy things going on. What I mean by that is if you have enlarged adenoids back there, that space behind your posterior nares is going to become blocked. Again, making it difficult or even impossible in some kids for the air to pass through from the nose to the mouth. I'm sorry, from the nose to the throat, resulting in open mouth breathing instead. So that's a big giveaway, okay? Tonsillitis, unfortunately, when we talk about it, it's considered a self-limiting issue. They'll be treated with antibiotics if they are positive, again, for that group A or B strep. Excuse me. Tonsillitis does not usually occur by itself. It usually occurs with pharyngitis. and then some treatment. So tonsillectomy, what I want you to know is it's going to occur if there are repeated episodes at a very specific severity. You don't have to memorize it. It's like 7 or more episodes in a preceding year, 5 or more in a preceding 2 years, or 3 or more episodes in each of the preceding 3 years. You don't need to know that. Please just know that we don't just take tonsils out right away. There has to be a pattern, unless it is so severe that we're talking about, again, air blockages. And when there is that sleep disordered breathing present. So we went from a quiet, comfy breather to a loud, noisy, open mouth breather. And then for adenoidectomy, because that's a component here, that has, again, its own set of criteria to meet before removal, and you don't need to know those. But again, remember, it's going to come down to if it's life-threatening with an airway issue. Okay. If tonsillectomy has occurred, though, some specific things I want you to remember and be aware of. Kiddos are going to be discouraged from coughing, clearing their throats, blowing their nose, or any kind of aggressive action that's going to aggravate that operative site. In a kid that has had their tonsils and or adenoids out, some secretions are going to be normal, right? Think about it. Just like if a growth or something was removed on the leg, there's going to be a little bit of exudate, a little bit of secretions, particularly now we're talking about sensitive tissues in the throat. That's normal. So what does that mean for you as the nurse? Taking care of a kid who just had their tonsils out, assessment is so important. Because you have to assess their pain. Is it normal post-op pain? Are we thinking, oh my gosh, the high level of pain seems a little bit abnormal, etc., etc. Nausea is going to be really common too after having your tonsils out. So we're thinking food and fluid restrictions that have to be enforced until kiddo is fully alert and there's no signs of a post-op hemorrhage. I bring that up because while post-op hemorrhage after tonsillectomy is uncommon, it can occur in up to about 5% of cases up to 14 days after surgery. And so here's where I want your critical thinking to start coming in. If you have a kiddo who has had their tonsils out and you're assessing regularly for this post-op hemorrhage, what are going to be some key signs? Well, obviously bleeding, increased heart rate, looking pale. This key one here, though, is particularly for the younger kiddos. We're talking about frequent clearing of the throat or swallowing. So if you've got a kid that just continuously swallow, I said some secretions are normal. But that continuous swallowing, not going to be normal. That means that there's bleeding and this kid is, their reflexes, their barometric reflexes, we have to swallow, we have to swallow, we have to swallow, otherwise they're going to choke, okay? Or an obvious vomiting bright red blood. Okay, so thinking about that, recall that, make sure that you understand what that looks like. And then if that were really to happen, I want you to think about what would be your very first action. We're talking about prioritization, right? That answer is going to come a little bit later in something else that we talk about, but for now I want you to kind of ponder that. What would I do first for the kid having the post-op hemorrhage? Okay. All right, moving on to flu really quickly. Not going to spend a lot of time on this one. There's 3 different types of flu, A, B, and C. A and B are the ones that cause the epidemic type disease. They're more severe. C is your milder illness. You're going to have some isolation precautions in place when this happens, when kids have this, particularly when they're in the hospital. We're talking about age, recall then, so obviously it's going to be more severe in your infants. And for anybody who doesn't know, the flu roughly has a 1 to 3 day incubation period, so not really long. Oops. Goodness. So signs and symptoms, flushed face, dry throat, gross nasal mucosa, a dry cough, a hoarse voice. Lights were going to bother people. They got the muscle aches, the body aches. They're cold, they have the chills, but then they have a fever. The thing about the flu that we want to really enforce here is it's not necessarily the primary infection of the flu that's so dangerous for kids, but it's the complications. Things like severe viral pneumonia, encephalitis, and then secondary bacterial infections that develop like an otitis media, a sinusitis, or a bacterial pneumonia. That's where a lot of the complication of the flu comes in and why we really want to work the prevention level. Examples, when I was in NP clinicals, I'd have a lot of families say, well, my kids still got sick last year and they got the flu shot. When I was working in respiratory season of 2018, what I was seeing is that the kids that came in who had a flu shot, they were in my not sick category. They didn't look great. They looked like they felt like crap, but they didn't need a lot of intervention. So they kind of felt more like they had a cold than they had the flu, but they were testing positive for the flu. Children who were not getting the flu vaccine that year, those kids were sick. They felt like garbage. They had lots of symptoms. Quite a few of them developed secondary bacterial pneumonia. So while no, does the flu shot always prevent you from getting sick? No, it doesn't, because the flu strain mutates. We know that. But getting the flu shot, in practice, I was seeing that those who had had it had less severe illness. So just things to consider. For your management, again, it's going to be supportive for your uncomplicated kiddos. Meaning that there's no secondary infections anywhere. Tylenol or ibuprofen, depending on age and things that are going on. Now, Tamiflu or oseltamivir is something that can be taken to, again, reduce the severity of symptoms. It's not a it's not a cure, it's not an antibiotic, it's symptomatic treatment that is more targeted. It can be for kids over 1 year old. But the thing is they have to be started on this within 48 hours of symptom onset, or it's going to be ineffective. So if I have a kid that comes in, and their symptoms started yesterday and they've gotten progressively worse, something that I ask families as the provider now is, well, would you consider treating with Tamiflu? And if they say yes, then we have the conversation about testing. Some parents don't feel that it's worth the test. They just want to make sure that there's nothing else going on. So something to keep in mind. All right. Otitis media. So there's a pretty big distinction here, and it can get kind of confusing for some people because we have otitis media, acute otitis media with effusion. So please look at box 21.5. And I actually don't have a page number for this one, sorry. Because I think that this little chart in there really breaks it down in a really great pictorial way. But regardless, otitis media is one of the most prevalent issues of childhood, okay? And just like everything else, bacterial ear infections are going to come highest in the winter, and it usually comes after a viral infection, so like your RSV or your flus. And that's really hard for a lot of parents, and I can understand that. I can sympathize. Daycares don't want kids that have that low grade fever, that 99.9, 99.5. But from a medical standpoint, most ear infections are viral in nature first. The bacterial ear infection develops when all of those goopy, yucky pathogens get stuck in the eustachian tube and aren't expelled, whether they have, this combination of an upper respiratory tract infection with, runny nose and nasal discharge. things get goopy, bacteria get trapped in there, they can't get out, then you have that secondary infection develop. But most families still want antibiotics for a viral ear infection. It's a very delicate dance to weave. Most acute otitis media does develop within the first 2 years of life, related to that physiology of the eustachian tubes that we were talking about. They have a different angle, they're smaller. That really plays a big part in it, especially if it's a daycare kiddo. And where else? Risk factors for ear infections, aside from the individual child doing something like daycare. Another one is having older siblings who are in school, because they're going to be bringing those viral pathogens home, which they may not get sick from, but a younger sibling would. Socioeconomic status plays a big factor here as well. So does parent or caregiver smoking, that secondhand smoke, or living with many people who are also smokers, has a big factor here, because that passive smoking or that secondhand smoke actually increases the risk of middle ear effusion. By it enhances the attachment of the pathogens to the respiratory epithelium in the middle ear. So those pathogens get in there, they can't seem to get out, they fuse into those tissues, and now we've got this prolonged inflammatory response, meaning that drainage through the eustachian tubes then does not occur. And you've got that effusion, that white, thick, goopy stuff inside the ear that gets stuck in there. And then it becomes purulent, and then we have an acute otitis media. Okay, so treatment overall, if it's a bacterial infection, it's going to be antibiotics, typically an amoxicillin. And then same thing with, like I was saying with the tonsillectomy, there are very specific criteria for having your tonsils out. There are also very specific criteria for having tubes put into the ears. It's not just going to be one ear infection and boom, you get tubes. It has to be a pattern, has to fit a set criteria. Usually when a child, from my perspective as a nurse practitioner, when a child is nearing the end of that criteria list where they've had multiple ear infections within the past year or preceding 2 years, that's when I refer them over to an ENT specialist to kind of take over that assessment from there. All right, mono, a quick one here. It's an acute self-limiting disease, very common in most people, very common in under the age of 25. It is caused by Epstein-Barr virus, and the incubation period here is pretty large. It's 30 to 50 days. Okay. Box 21-7 has really good info on mono. Again, I'm not going to go over this in depth because it's a pretty simple viral infection. The main thing I want you to remember is in a kiddo that has mono, they're at risk for splenomegaly, so inflammation and a bigger size of the spleen. And in our kiddos who play sports, it's going to be very important to limit the contact sports because they can rupture their spleen if there's splenomegaly and they take a hard hit. All right, so now we're going to move into talking about the croup syndrome. So I want to draw your attention to box 21-1. I know I keep talking about these boxes, but I truly believe, both from a former student not all that long ago and a faculty standpoint, that these boxes and tables are instrumental in effectively studying. Rather than making your own boxes and tables, they're already here and they summarize these points. So please take a look at them. But anyways, croup syndrome. So there's a couple of different pieces that come into play with these. Again, generalized info here about it first. They're characterized by this hoarseness. We're going to talk about the one that has the barky cough, that inspiratory stridor I was talking about earlier, and then they each come with varying degrees of respiratory distress. So we're starting with croup syndromes first, and things that I want you to remember. Remember, you're not here in this pediatric course to become a certified pediatric nurse. You're here to be a safe generalist nurse. What that means is you have to be able to identify life-threatening emergencies. And there are some among the croup syndromes. So that's where we're going to start here. So croup affects the larynx, the trachea, and the bronchi. Okay. Within that, we have the epiglottis, we have epiglottitis, laryngitis, laryngeotracheobronchitis, or LTB, and tracheitis. So those are the ones that we're going to talk about. First, acute epiglottitis. This is a medical emergency. And I mean that in the most severe, serious way possible. Acute epiglottitis can lead to death if not managed appropriately. For a while, we weren't seeing it as often, but with the rise of the unvaccinated population, especially here in Alaska, we have seen a few cases in the past couple years. So, acute epiglottitis. Clinical manifestations, sore throat, pain, tripod positioning, so that leaning forward to be able to breathe better. You're going to see retractions. You're going to hear inspiratory stridor. They're going to have maybe mild hypoxia to start and distress. So let me back up just a second though. Acute epiglottitis. Break that down, even if you didn't know what it was. We know that itis means inflammation. You know where your epiglottis is, what it does, correct? Hoping you're all saying correct. If not, go look it up. That's not something you should be learning in a 400 level class. So put that together. If you have an acute onset of swelling and inflammation of the epiglottis, we have a serious and severe obstructive inflammatory process occurring in that area, and that is life-threatening. We're going to see this predominantly in ages 2 to 5, but can occur from infancy to adulthood, actually. Okay. And so your management here is going to be that protection of the airway. Okay. And I said the onset is abrupt, and it's very, very true. Typically, your classic case of this, kiddo is going to go to bed, they're going to feel fine, they're going to wake up in the middle of the night with progression from respiratory distress to severe respiratory distress. So that means they're going to wake up complaining of a sore throat, maybe some difficulty swallowing. They could have a fever, but overall, again, sick or not sick, when you look at a kid, this child is going to look severely ill in comparison to what seems appropriate for what they're talking about. So they're telling the mom and dad that they have a sore throat, maybe they've got a fever, but they look ill. And that is because of the process that's going on inside that you just can't see. Remember, tripod positioning, sitting upright, leaning forward. The chin specifically is thrust out, mouth will be open, and the tongue will likely be protruding. I said difficulty swallowing, difficulty breathing. So there's going to be what? Especially if you're thinking of this age. A lot of drooling. So excessive secretions. The drooling kiddo here is a classic sign. What happens when you have hypoxia and people in general aren't getting enough oxygen? They're irritable, they are restless, they're anxious, and kiddos with this will be very scared. Another classic, but not always present, sign is a thick or muffled voice, because again, think about where that epiglottis is. However, initially, they will not appear to be struggling to breathe. And so that is where again, the look of them versus what they're talking about or complaining of is very contradictory. Another distinctive classic characteristic here is the cherry red epiglottis, visible on careful inspection. And I say that, but I'm also going to follow it up and say in the treatment here, our management, it is contraindicated for you as the nurse to examine this kiddo with a tongue depressor or to get a throat culture. until there is an appropriately trained medical professional, so a physician or an NP, who can intubate or perform a tracheotomy, because that's how serious it is. Okay. Diagnosis and diagnostics here, a lateral neck radiography will be able to provide the definitive diagnosis if the inspection is not able to occur. Treatment is going to be some combination of steroids, antibiotics, fluids, and again, that airway protection. Nursing, here the big piece is continuously monitoring that respiratory status. Okay. Now, acute laryngitis, pretty simple compared to that one. It's more common in your older kids and adolescents, usually viral in nature. They're going to have that hoarse voice, that really scratchy, squeaky kind of voice. It is typically self-limiting and without any kind of long-term consequences of it. Because it's viral, treatment is symptomatic. Rest the voice, increase fluids, Tylenol, ibuprofen as needed. Now, acute laryngotracheal bronchitis or acute LTB is the most common croup syndrome. It's going to typically affect your kids younger than 5. There's a couple of different organisms listed here that are common. So overall, your signs and symptoms, you're going to start as an upper respiratory infection. And then remember what I said, in the younger ages, because of the way that everything is positioned, it's common for things to migrate downwards. So the upper respiratory infection is going to move down and descend into, close by or adjacent areas. So there's definitely going to be a low-grade fever. And this kiddo is going to look like they went to bed and then they woke up with this barky or brassy cough. And I had a patient when I was in NP clinicals. It was an older grandmother brought in the 9-year-old child, and she said that the cough sounded like a moose call. And I was still newer to Anchorage, hadn't really encountered a lot of moose at that point, and that has always kind of stuck with me. I still haven't heard a moose make a noise that sounds like this cough, but for anybody who's lived in Alaska longer than I have, perhaps that's the case. I'm not sure. To me, it's still that barky, seal, very distinctive cough. I've heard this cough on airplanes, and I'm like, ooh, that kid's got croup. Somebody get him to their provider. Very distinctive cough. So you could even, look it up on YouTube, croup cough, and see what you find. The cause of that cough, so again, thinking inflammation of that mucosal lining in your trachea and in your larynx. And if we have inflammation, what does that mean? We have an airway narrowing. So to get the air into the airways, it has to get past the obstruction to get into the lungs. And so that's where you get that very characteristic inspiratory stridor noise. And if you don't know what I'm talking about when I say stridor, please look that one up on YouTube. It's an important one. Very, very, very characteristic sound. Okay. And then there's also going to be suprasternal retractions because they're not getting enough air in. And so thinking about what I said, how it starts as an upper respiratory infection. So maybe there was a runny nose, a little bit of a sore throat for a couple of days. Then it's going to change into this. Now they've got maybe a low-grade fever or a slightly higher fever than where they were. And they now have this bark or seal-like or apparently moose-like cough. Okay. Now, if it's not treated and managed, then we're going to start moving into respiratory distress and hypoxia because, again, obstruction, not getting enough air. And then if it's truly not managed and it progresses, because that inflammation is not going to stop without something to pause that process, we're talking about leading to respiratory acidosis, respiratory failure, and death. Okay, so what is the management of this croup syndrome? Again, first things first is your airway. Can't do anything if the kid can't breathe. And so what do we do for that? That is going to be making sure that they're sitting in a position that they can breathe in the best, obviously. For mild cases, cool mist, though you will see in the literature, is still considered controversial and not necessarily evidence-based practice, but it is effective in most mild cases because it constricts those edematous blood vessels that are all up in there. Okay, so if you've ever heard of a parent who said their kid had a cough and they took them outside in the middle of the night and that helped, that's croup. Okay, or they put them in the car for a drive because they were restless and couldn't sleep and rolled the windows down and then the cough got better. That's croup. For the kiddo who has slightly worse croup, there's a couple of different things. So nebulized epinephrine or the racemic epi, that's for your severe disease here. So we've got that stridor at rest, there's retractions, difficulty breathing, that we're moving into respiratory distress, and you can visibly see that in this child who needs the racemic epi. Otherwise, for mild to moderate cases, they can be managed with just steroids. And the steroid of choice here is going to be dexamethasone, preferably PO, but again, thinking about the child that I'm describing, there's a chance that they're not able to swallow or get that medication down. So there is an IM available, but PO is preferred. And then from the nursing perspective here, your role assessment. What does this kid look like when they come in? Vitals. What's their pulse? What's their respiratory rate? Are there any retractions? Nasal flaring? Do they seem restless? All of those are going to be cues to you as the nurse about where they're at as far as their hypoxic state. Okay. Most of the kids that I've seen with croup come into the office and are appropriately managed without an issue with PO dexamethasone. They get that, they sit. You can hear the change by the time that they leave. But the kiddo who has the severe disease, that kiddo needs to go to the ER. And that kiddo needs some serious help in order to prevent death. Okay? All right, acute spasmodic laryngitis, it's distinct from the other croup syndromes, okay? So it's known as spasmodic croup or midnight croup. This one is recurrent paroxysmal attacks, meaning it happens, but only at a certain time, and in this case, it's going to be at night, okay? The inflammation is mild or absent compared to the other laryngitis croup scenario we were talking about here. And the management here is going to be the same as the infectious croup. All right, bacterial tracheitis. This guy's not that good either. So it has features of both croup and epiglottitis. So without knowing anything else, thinking about what I just was describing with croup and epiglottitis, this one's pretty serious, right? So we've got an infection of the mucosa and the soft tissues of the upper trachea. The average age of the onset is going to be 5 to 7, but also younger than 3. I know that doesn't really help much, but just think of it as literature is great, but sometimes it's conflicting. So how do I want to phrase that for you? Let's say 3 to 7 to make it simple. If this was an exam question, it would be very clear what I was talking about, because I hate when there's conflicting info. about things like that you have to get stuck reading. But obviously, in your younger child, if you have that kiddo who's getting it at 3 or younger, it's going to be worse. Why? Because of all those pieces that we talked about before. Your 5 to 7-year-old, again, a little bit bigger, but still small airways. We're not at that, adolescent size yet. So either way, not good. And this can actually be seen as a complication of LTB. Oh, I really have to stop doing that. There we go. Oops. See? There we go. Okay. And within that, thinking that if it's a complication of LTB, Staph aureus is actually the most common culprit of bacterial tracheitis. So, what does it look like and what do we do for it? So the signs and symptoms are going to be the same as LTB, but will actually then be unresponsive to the same treatments. So the kind of kid that we're looking at here, previous history of a URI with that croupy kind of cough, stridor, we're not really able to fix that with positioning. There's not typically going to be drooling or a high fever, but there will be really thick, very purulent secretions, and on a CBC, you're going to see an elevated white blood cell count. So what are we going to do for this kid? It's O2 therapy, antipyretics, and aggressive antibiotic treatment. And I say aggressive and really highlight that because most of these kiddos, unfortunately, will end up having to be intubated due to that tracheal restriction because of all of these yucky secretions that we're talking about, thick, purulent. If you're thinking about that in your trachea, you're going to need to be vented for at least a little bit until the antibiotics kick in, okay? Okay, so bronchiolitis and RSV. I've mentioned at least RSV quite a few times. I think I've mentioned bronchiolitis. So when it comes down to it, bronchiolitis is a really common, mostly oftentimes an acute viral infection that has both upper respiratory symptoms and lower respiratory symptoms due to this really bad inflammation that happens. By about 3 years old, most kiddos have been infected at least one time. And in our younger population, under 1, RSV is the most common reason for hospitalization for those kiddos during respiratory season. And I did mention that previous RSV infection can be seen as a risk factor for other respiratory infections, and that's 100% true. In fact, it can, like, severe RSV infection within the first 12 months of life can actually represent a really significant risk for developing asthma later on in life. So, RSV is actually important to note, transmitted from contaminated secretions. So, it can actually live on hands for up to 30 minutes. So, like for me, having a due date in October, I'm a little bit concerned about RSV season and people wanting to be up close to baby and things like that. So, we always talk about hand washing even before the pandemic. This is one of the reasons why, because RSV can live on your hands for up to 30 minutes. And an adult that's infected with RSV will maybe have like a little cold compared to a 4-month-old with RSV who could potentially be hospitalized depending on how severe it is. So when we think about the patho for RSV here, ultimately RSV affects the epithelial cells of the respiratory tract. The maximum obstructive impact is at the bronchiolar level, and that's why bronchiolitis. So again, if you're getting stuck on some of these terms, break them down and then think about where that anatomy is. Okay. Important to note, usually we're going to be thinking kiddos 2 to 12 months old. Again, rare after 2 to have a severe RSV infection that leads to bronchiolitis. So, and that's something that I want to make sure is clear. RSV is respiratory syncytial virus. Bronchiolitis is usually a result of RSV. Okay, they're not the exact same thing. One is the virus, one is what happens when RSV becomes really bad. Sorry, I had to pause it because somebody was at the door and the dog was about to go bananas again. Okay, and so like I was saying, bronchiolitis and RSV not completely synonymous. RSV is the most frequent cause of bronchiolitis, but there are other viruses like adenovirus, parainfluenza virus. It really just depends on how the virus settles in, if it travels, because again, remember, small structures equal closer passageways, things like that. So as far as diagnostics, we've got RSV swabs. They're not fun. Kiddos don't like them. I've also seen RSV washings. I'm not sure how often that's happening though at this point. But we've got a rapid, and then the I call it ELISA. I've heard it's ELISA is the acronym. I'm not sure how other people pronounce it. But essentially, yes, there is a test for it. We test it. And then from there, for mild cases, kiddos can stay at home if they're maintaining their hydration and are not in respiratory distress and don't need oxygen. Obviously, as we move up that continuum of severity plus potential complications, that's when we're going to see our kiddos having to be hospitalized for this. Now, there is prevention. The brand name of the product is Synagis. It's an IM injection, 5 doses total, and typically it's going to be kiddos who have higher risks, and that's kind of where I want you to be for that one, okay? All right, pneumonia. Okay, so I'm hoping that now pneumonia itself is going to be a bit of a review. So what I'm going to focus on are the pediatric distinctions. So most pneumonia cases in kids are going to be viral. Honestly, most pneumonia is viral for kids and adults. It's when we get into the bacterial ones that we are seeing it as like a secondary complication of something like influenza that we talked about. Or it can even come up as a secondary complication of like a viral URI. It just really depends on how things migrate down, again, because of that anatomy. Aspiration, that's another big reason that happens, aspiration pneumonia. And in our younger kiddos, that's a more common piece because we know that they like to put everything in their mouths. So again, I know that we say this a lot. It seems like it just in this PowerPoint, but the manifestations are going to vary depending upon the age. Resistance factors, as far as if it's bacterial, resistance to antibiotics, and the degree of the obstruction. So, little question here. Which of the following interventions would be an appropriate nursing intervention when caring for a kiddo with pneumonia? Are we encouraging rest? Are we instructing them to avoid lying on the affected side? So, which lung is it in? Are we going to give analgesics or put the kiddo in Trendelenburg? So think about it. What do you think it might be? Think about your prioritization. And answer is A. So encouraging rest by overall clustering the care and promoting a healing environment is going to be best for a kiddo with pneumonia. lying on the affected side may actually promote comfort by splinting the chest and reducing that pleural rubbing that's going on in there. And as far as positioning, I don't know any kid that would want to be in the Trendelenburg position for this. So again, positioning for comfort like we talked about before. All right, moving on to pertussis. So I have actually seen an increase in pertussis cases just in the past, I don't know, 3 years, mostly due to that increasing percentage of the population that's not vaccinating. So we know that pertussis is caused by Bordetella pertussis. Again, most often occurring in kids who have not been immunized, and that includes kiddos who cannot be immunized for it yet. Your peak is going to be spring, summer for this one. Very, very highly contagious. Obviously, the biggest risk is to our younger kiddos. And then, excuse me, for those of us who do get vaccinated, it's not a lifelong vaccine. You do have to get the booster for it to continue to be as effective. Foreign body aspiration, I mentioned this just briefly. So thinking about your growth and development pieces, most commonly going to occur between 1 to 3. They're learning how to eat. They're putting everything into their mouths. They're working on those gross motor skills of actual mastication, moving their jaw around, chewing, etc., etc. Important to note, obviously we're talking about a foreign body, so can result in life-threatening airway obstructions. This is again where your assessment of the kiddo is going to be imperative. And then educating, prevention, taking it back to that anticipatory guidance piece. What kind of anticipatory guidance would you be giving to a family with a kiddo in this age? That's something that I want you to think about. That's the kind of question that I may ask in relation to something like foreign body aspiration on the exam. So with that being said, aspiration pneumonia, this is also a really big concern in kiddos who have feeding difficulties. So our kiddos with disabilities, kiddos with extra swallowing needs, things like that. This is where that comes into play, in addition to our kiddos who are in that prime time age for foreign body aspiration. So the biggest thing to do then is prevent aspiration from occurring. How do I do that? Cut food into small pieces, provide small bites, provide enough time in between bites of food. The very simple interventions, right? And so nursing really is in a fantastic role to be able to educate families about this. Anticipatory guidance at every visit. There's all depending. So I've done clinicals at a school for children with cerebral palsy, and their school nurse was phenomenal. She would put on like once or twice a year educational sessions for parents. Obviously, parents are in that case with kids with CP, especially depending upon how severe it is, are going to be experts themselves on providing that care. But recommendations change. It never hurts to provide that education. And her reasoning was, we get new kids all the time, and we lose kids here all the time. They go to different schools. We have new parents with new diagnoses. Just really reinforcing the good techniques and all of that piece is important. Okay, that's what we're going to say about that guy. The rest of this is going to go pretty quick until we get up to asthma. So acute respiratory distress syndrome, ARDS, again, pretty common. This one's really straightforward, nothing tricky here. The content in the book, again, straightforward. Just be aware of the overall patho. Why is it happening? What do we do? And focus on your role here. So asthma. If you took a look at the PowerPoint before, you've seen that there's quite a few slides on this. I'm going to help you figure out how to focus it in because there is so much information about asthma. It is all important, and so I've left most of it in the PowerPoint so that you have it just kind of here for your own notes, as I did, again, post this in the files. But there's a few pieces that I want you to focus on. So, asthma, chronic inflammatory disorder of the airways with recurrent episodic symptoms, and that's really important. Kids don't get diagnosed with asthma based on one episode of wheezing. So when I see kids come into the clinic, in respiratory season especially, or they come in for cough or wheezing, one of the first things that I look at in their history is if they've ever had wheezing before and if they've ever used an inhaler before. Because asthma itself is diagnosed based on history. Repetitive occurrences of this happening. That's why it's chronic, not just one time. A kiddo can have a cold and have some expiratory wheezing and need an inhaler one time without needing it again and or being diagnosed with asthma. And so educating families on that difference is it's not listed on this slide, but is going to be a really important nursing role here because, families think, oh my God, inhaler, oh my God, that means asthma. Or if they're not given that education, what happens frequently that I see in practice is families come in and say that their child has asthma, and I get to look back in their history if they've been there a few times and they don't have asthma, but the child has had wheezing. And so that is a really important distinction that I want to make and for you to understand when it comes to pediatrics. Wheezing is not synonymous with asthma, though it does occur in asthma, okay? So other recurring episodic symptoms are that breathlessness, that tight chest, and the cough at night, especially at night, that wakens them up. So again, we're talking about all this A&P stuff. When you're thinking about asthma, thinking about the anatomy is so important. So we've got a limited airflow or obstruction that reverses spontaneously or with treatment. So it can happen on its own. More often than not, it's going to need medication. And then bronchial hyperresponsiveness. If I was with you guys in person, I would ask you what that means. So I want you to think about it. If you don't know, look it up. And it comes up again later, so hopefully you'll know by then. So let's look at this. So here we go. When a kiddo has asthma, we are talking about all of these structures being impacted, okay? Looking at the kiddo with the asthma, look how leaky things look. You've got mucus up in the bronchioles. There's like a nice little actual plug of it. The alveoli are hyperinflated. Mucus is going to accumulate in all those other structures. The smooth muscle is constricted, where over here, everything is nice and smooth and open. Your alveoli are the right size. You can see the differentiation of your goblet cells. Your epithelium is nice and smooth. And so even if you didn't understand anything else about asthma, if you could understand and retain this information about the anatomy impacts and then the pathophysiology relating out of that, you should be able to answer almost any asthma question. Almost any. Not all, but almost any. Okay? And so overall, what are we saying here in looking at this? We're saying that the inflammation, so hyperinflation, constriction, all of that is inflammation, contributes and causes this really heightened airway reactivity. Trying to see if there's anything else I want to say about that. Oh, yes, bronchospasm. So we've talked about inflammation, we've talked about obstruction of the airflow because of that, and then there is that bronchospasm piece. And that's really important. That's kids feel like they can't breathe. They feel like they've got this constricted airway, and that causes that apprehension and that fear that come with that piece of the hypoxia. The severity classification, this is just for your knowledge. You do not have to memorize this. Just know that there are the different levels, okay? Whew. So diagnostic evaluation. There are a lot of pieces to this. So basically, when we're seeing kids that have that dyspnea, the wheezing, and the coughing over multiple times, multiple episodes, then we're going to start to try to figure out what exactly is going on. I use the NIH guidelines, and I think for my purposes as a provider, it's set up very nicely. I think for your purposes as a nurse, it's a really good reference to just kind of have an idea of what these mean within that classification. Again, not something that I need you to memorize, but if you, depending on where your future practices, that would be something to come back to. So things that we use for diagnostics here, pulmonary function tests. This is going to give you an objective method for looking at the presence and persistence or degree of lung disease. Spirometry and PFT are different though. A lot of times people will get that mixed up. A spirometer, you blow the little ball up and down, right? That's what we give to our patients to prevent atelectasis. Pulmonary function test, very different. Another measurement that's within this diagnostics is the peak expiratory flow rate, or the PEFR. So that one's measuring the maximum flow of air in liters per minute that can be forcibly exhaled in 1 second. You don't have to know how that applies, just know that those are the terms that are going to come up. Again, if you were working in peds, that's something you would need to be more knowledgeable about, but for now, just be aware of it as a thing, okay? There's a couple other pieces that you'll see in the reading. I don't feel that there's so much that you can only know so much. And at this point, those are the ones that I want you to be able to recognize. Then, as far as therapeutic management, just like any other piece of nursing, our biggest goal is always to maintain the most and highest level of functioning for our patients. And in here, that's for children, what would that be? Maintaining normal activity levels, keeping their pulmonary function in tip-top peak functioning, preventing chronic symptoms and recurrent exacerbations. And then when we're providing medications, obviously a goal is to have as little or no side effects at all. So what is all of that really saying? We want a kid to be a kid despite having asthma. So one way that we do that is non-pharm therapy. So for kids with asthma, that's things like allergen control. Depending upon their particular triggers, is it pets, is it dander, is it dust, is it pollen? Really kind of figuring out each individualized child's allergen triggers is important. In Alaska, the cold is a big one, and there's only so much you can do to contend with that, as opposed to, pets and cleaning and things like that. For kiddos who also, it's worth mentioning, for kiddos who also have the allergen component to their asthma, getting them over to an allergy specialist to really key in on what their allergens are can help with the medical management of the asthma. Then the other piece is obviously drugs. We're going to have to provide medications for most kids with asthma. We'll get to that in just a second. So other big nursing considerations that I want you to be thinking about is how do you then as the nurse help support the child in that big therapeutic management goal, which is to still be able to live like a child. So that includes lots and lots of education, lots, of support for the family, especially if this is the first time that anyone in their family's ever had asthma. How do we support the child in still being able to obtain their favorable outcomes, their growth, like their physical growth and development goals? How to help them feel just like everybody else, because obviously the older they get, that's something that sticks out more. Pieces like that. Then there's going to be the education about medications and how to administer them, things like that. So again, in asthma, the medications are really in depth. I kind of want you to have more of this overview of what they are. I still remember though, I can tell you my NCLEX had most of the medications on my NCLEX I never even remember studying or seeing or hearing talked about, and most of them were for asthma. And I used context clues of the scenario, etc., 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 to answer the questions. But just know, especially for something like asthma, there's always going to be new meds coming out, something fancier, something that they think is more effective. And that's why I want you to be able to focus more on the class of the drugs for asthma, so that if you looked something up and you saw, oh, it's an MDI, so I know that a metered dose inhaler is going to provide the prescribed amount of medication in one puff. It could be like an albuterol, or it could be a powdered MDI. That's the kind of piece that I want you to be able to know when you see something like this, versus all of the different names of it. So don't get too hung up on that piece. So overall, we have long-term control medications, which work in the preventative sense. Then we have your quick relief medications, your rescue inhaler, like your albuterol. Okay. You have a metered dose inhaler, like I just said. It can be either like aerosolized, or it can be a powder. Then steroids, and sometimes steroids are used in an acute way for an exacerbation, and sometimes, depending on the severity of a child's asthma, it can be used excuse me, for prevention. Your cromolins are going to be used in maintenance therapy for your kiddos that are older than 2. It's got this stabilizing component for your mast cell membranes, which essentially helps to reduce the amount of acute airway narrowing. Not all kids who have asthma will be on that one. Again, here's some other ones. We've got your long-term bronchodilators, like your salmeterol or your Ceravents, the Ofalin. I do see that one pretty regularly. The same thing with your leukotriene modifiers. I mentioned albuterol. And then the last one says others, because there are so many more. So overall, when it comes to meds for asthma, I want you to be aware of the different classes so that you understand why they're on that, what it's for, versus specific names. Now this picture, for anyone who doesn't have asthma or who's never seen it, and here you're using an inhaler and a spacer. I prescribe spacers even for my teenagers who have asthma or exercise-induced bronchospasm, EIB, which we're going to talk about in just a second. The reasoning behind using the spacer is because more of the medication is likely to get into the lungs using the spacer versus taking it directly from the inhaler. Because think about that. If you have an inhaler, you shake, 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 you put it in your mouth and you breathe in. Directly from that, you're trying to coordinate breathing in, moving your tongue out of the way, holding it, blowing back out, all in the, quick, like nanosecond it feels like the medication came out. especially with a younger child, when you're using an inhaler with a spacer or an antechamber, it's listed in all these other different ways. The child has the opportunity to let the medication sit in the chamber so that they can be completely ready and not trying to, I hit the button and now I'm trying to suck all the medication in. So just FYI. Okay, so exercise, like I said, from a nursing standpoint, one of the big components we want to make sure is that they maintain the level of activity that's appropriate for their age and stage. For some kids, especially because we have the obesity epidemic on the rise, there is a lot more exercise-induced bronchospasm, meaning that intense physical activity triggers that bronchospasm in there. I actually just prescribed an inhaler for a 15-year-old, 16-year-old, 16. He is overweight and is really trying to work on his weight management, and in doing so is engaging in more intense physical exercise, and as a result of that has been having some wheezing, some difficulty breathing, a little bit of chest tightness, ultimately culminating in EIB. So I prescribed him a rescue inhaler. CPT is also another intervention. Helps loosen up all that mucus in there. Breathing exercises and hyposensitization. Again, trying to reduce the amount of triggers and getting the body used to those. Activity as tolerated is something that you're going to hear pretty commonly for kiddos who have asthma. What's their activity as tolerated today? That's going to be based on what kid says. That's going to be based on what parents see, etc., etc. Status asthmaticus. So this is continued respiratory distress despite therapeutic measures. It is considered an emergency, and they're going to need some epi. And we've talked about epi before already. This can occur if there is a different concurrent infection going on, and that's when I've seen it both as a peds nurse and a provider more often. So one of the most important things for the nursing role, aside from all the education and assessment, is to be calm. Kids with asthma, again, thinking hypoxia, apprehension, anxious, they can't get enough air in, they know what's going on, especially if this is a kid with recurrent exacerbations. Your ability to maintain calm, even if you're freaking out on the inside, is going to be instrumental in their positive outcome. Okay? Obviously, a pulse ox, we always want that. I always have that on kids with their vitals just because it gives me so much more information. Positioning is important, and we've said that a few times with a few different pieces of respiratory care. No different here. And even though some places will want parents to be out of the room, we are focusing on that family-centered care approach, so allowing parents to remain with their children even in an acute asthma attack is going to be really important. I think that there's a fine line though when you have a parent who's interfering and not listening to redirection and being able to get your nursing interventions completed. So keep that in mind. And again, here's another position, so semi-erect, so sitting up a little bit but also sitting back. Recurrent asthma kiddos are going to be most of the time experts in their care. So listening to them as an expert on their bodies is really important, and it supports the favorable outcome. Okay, so I've mentioned most of these. The only one that I didn't really talk about as far as goals is self-management. We really want to promote the autonomy as much as possible so that the kids are managing it, if it's age appropriate, compared to the parent. So making sure they understand how to use their medication, when to use their medication, how to do it appropriately, how to monitor when they need to sit out in activity, those kinds of things. Okay. All right, moving on to cystic fibrosis. Now, there's quite a few slides here about CF. and we're going to breeze through some of them and focus in on some of the other pieces, because I know CF has been coming up on the NCLEX. So cystic fibrosis is a genetic thing. It's an exocrine gland dysfunction that has a multi-system involvement, which we're going to see here in a few. It is the most common lethal genetic illness among Caucasian children. It's an autosomal recessive, so the kiddo with CF has had to inherited it from both parents, and you have a rough overall incidence of 1 in 4. So if a family has 4 kids and one of them, or both of them rather, are carriers, there's a 1 in 4 chance one of those 4 children is going to have it. So the patho, there's a lot of things going on here. It is all very straightforward, the reading in the book. So I'm not going to spend a lot of time pinpointing this with you, but you are going to need to review it in the reading. Okay, so there are several clinical features that ultimately CF is a results in mechanical obstruction. So their mucus gland secretions are very thick compared to somebody who does not have CF. Very, very viscous. And that ends up being one of the big, let's call it a trigger for some of the other clinical manifestations and multi-system involvement. And the additional, so the pancreas is also involved in this. So the pancreas and the GI system are going to be kind of that secondary system when I'm saying multi-system involvement. Elevation of sweat electrolytes, absolutely, that's important here. One of the diagnostic procedures is a sweat test for kiddos with this. There's some changes in their saliva. Their autonomic nervous system is going to have some dysfunction and some changes compared to other things, or people without that. And there is again, that sweat test, so there's an increase in sodium and chloride in both their saliva and their sweat. And those levels are going to be anywhere from 2 to 5 times greater than in somebody without it or in a control group. Okay. When I was in undergrad, I worked at a children's hospital as an aide in their ambulatory clinics. And it was a big hospital, so there was a lot. It was Lurie Children's in Chicago. And I frequently worked the genetics clinic and saw a lot of CF patients, both diagnosed and managing, and our younger kiddos in the process of getting diagnosed. And it is possible for these kiddos to live a full life when they're younger. It really is going to just depend upon the severity of their disease. I think this is a helpful flow chart. I think a few of you I've talked to about studying and how to do it. I really think for a lot of these disruptions, flow charts are very helpful. It's to the point, it gets the patho in, it provides that thinking component from what am I hearing and seeing, why is it happening, and then what do I do as a nurse. This one doesn't go that in depth. Most of those ones that I'm talking about, you would make yourself, but this is where it starts. Okay, so what I've been talking about this as being like a severe thing, but what does that actually mean? So kiddos are going to have COPD, essentially, chronic obstructive pulmonary disease, and it is progressive. They will present with failure to thrive. They are going to have weight loss despite still being hungry. Their respiratory system and capabilities are going to deteriorate in a gradual function or fashion rather than kind of that really rapid, like with acute epiglottitis. So our kiddo with CF is going to have a wheeze. They're going to have a very dry, non-productive cough. And think back what I said. They have very thick secretions, but nothing comes out. Okay. They will have some kind of like random patchy atelectasis. Their clubbing of the fingers and toes, that's a big one. That's a classic sign. And they're going to have repeated infections, pneumonia, and bronchitis. One of the earliest possible signs that we would see in a kiddo with CF would be a meconium ileus. The distal intestinal obstruction syndrome, that's another one. A big classic sign is going to be the stool. So it's bulky, it's frothy, it's very foul smelling, because remember, their failure to thrive, and we talked about there's only really, 3 technically, but 2 big components of failure to thrive. Either they're not getting enough or their body's not using enough of the calories that they get. And in this instance, it's a malabsorption processing issue. The girls will have delayed puberty, and males will be sterile who have CF. They're prone to frequent dehydration. And because of that salt-sodium issue that they have going on, they've got a lot of electrolyte issues. Okay, so for diagnosing, I mentioned that sweat test. They're also going to have the things that we were talking about with asthma, the pulmonary function test. They'll have a poop sample taken, and we're going to be looking for how much fat is in there and what kind of enzymes. They could get a barium enema as well. Respiratory, obviously, in cystic fibrosis, it's going to be in almost all our kids with CF, but the onset and the extent of it are going to vary based upon how serious theirs is, their level of functioning, how thick their secretions are, those pieces. So on the more serious side, due to those really thick secretions, the obstruction in bronchi and bronchioles, for the patient with CF who has severe disease, we're talking about things happening like compression of the pulmonary blood vessels, progressive lung dysfunction, which is going to lead then, thinking about some of the biggest issues with respiratory, pulmonary hypertension, cor pulmonale, respiratory failure, and then obviously death. That's that really severe side of it. Not every child has it that bad, especially right off the bat. And the life expectancy of patients who have CF is increasing compared to what it used to be like, but many will still need a lung transplant in order to live into the later ages. Infectious pathogens, here that means in relation to issues with CF. We've talked about this already. And this. Okay, so the GI, there's a couple GI ones. I really want you to just be able to know that the secretions that we were talking about having such an impact on the respiratory system are also going to have an impact on the GI tract. So we're talking about things like this cystic dilation, degeneration, and kind of some diffuse fibrosis within there. Due to those thick secretions, I mentioned the pancreas earlier, so pancreatic enzymes are going to have a really hard time getting to do their job, which is within the duodenum because of those secretions. So without those pancreatic enzymes, then we have impaired digestion, leading to an increased, we've got all that fat in there, and then the steatorrhea, which was that really bulky, foul, gross poop, happens. Important if obviously we're thinking about pancreas, if we've got ongoing issues with the GI involvement here, it's possible that diabetes can occur. So our overall goals shouldn't be a big surprise. Maintaining as great of a function both for their respiratory system, their GI system, and this child's life overall. Maintaining adequate nutrition, because we've talked about failure to thrive, so that's going to be a big hurdle to overcome. And then a lot of patient and family support for adapting to life with a chronic illness, especially one like CF. So what do we do as far as respiratory management? We've been talking about all these thick secretions and all this crazy dysfunction within their system and their anatomy. Obviously, bronchodilators. Boom, that's going to be your number one. When they get infections, obviously prevention is number one here, but if they get them, aggressive treatment with antibiotics and trying to keep them out of the hospital if possible, because they are immunocompromised. So that's going to be looking like home health care, like IV antibiotic therapy. CPT, chest physiotherapy. So that's getting thumped on the back. That's how I would hear the teenagers refer to it at the clinic. Getting thumped, which will break up that mucus in there. And now there's all sorts of cool advancement stuff. There's the like CPT vests that patients can wear that provides that vibration to break that kind of stuff up. And we've got a kiddo using a mucus flutter, which again, trying to break up, most of these goals are about how to break up that thick mucus in there. Things that we're working with, pneumothorax is common. We want to prevent that from happening. NSAIDs, obviously, right? Reducing the inflammation, trying to create as much space as possible in those airways. And then I mentioned transplant previously. Our GI goals, things that we want to do, making sure that are happening. We talked about nutrition, so making sure they're getting not just the minimum but above, because we know that they don't absorb everything. Constipation is a big issue for them, so making sure that that doesn't become severe. Watching salt, make sure that their sodium levels are appropriate. They're going to have GER, so making sure that we're doing simple things like positioning. If they've got diabetes, obviously looking at their glucose levels, making sure that their exercise is where it can be. And the eye exam, we're talking about the endocrine management, if they've got the diabetes and the enzyme impact there. We know with diabetes regularly, eyes are an issue. So the overall prognosis in 2008 for a kiddo with CF was at 37.4 years. I know that that has gone up now. We still consider an incurable disease even in somebody who's had a transplant. But the transplant potential has increased the expectancy. And so when we're talking about lung transplant, the survival rate is actually 75% at 1 year and then 55% at 3 years following transplant if they're still infection-free and doing well. We talked about family support. I mentioned it quite a few times. These children are therapy intensive. They require a lot of care. And so that's a really big component of that. I've got a couple of these on here. I want you guys to work through them. before I provide the answers, there's going to be some learning activities that have some case studies with answers, and I'm going to come back to give you those answers. In that, I want you to try to answer them for yourselves first and see what you come up with. Okay? All right, so that is the end of the respiratory content. It's a long one with a lot of pieces in there. Some of it I breezed over, some of it I've directed you where to look further in the book because it's just very straightforward and you need to know it. The group assignment will really reinforce a lot of the respiratory content. So you're going to get that reinforcement of that when you work within your group. All right, let me know if you guys have questions.